Hello, everyone. Welcome to another virtual morning report. Really excited to co-discuss with another hospitalist who is Mengyu. I'm a hospitalist here in Atlanta, and Mengyu is also a hospitalist. Mengyu, you want to say a word?
Welcome everyone. Yeah, I'm a hospitalist in Portland, Oregon. Very excited for the session today.
That's awesome. And the people who are making it happen, Simi, you want to say a word?
Yeah, hello everyone. Very excited for the session today and happy to describe.
Mohammed, calling from Baghdad.
Hello, everyone. I'm Mohammed, medical graduate from Iraq. I'm excited for today's case.
Yeah. And Ram, welcome back. Which case number is this?
This is case number three. But yeah, excited to be here. Just want to thank Dr. Austin Rizik for helping with this case, as well as Rahul, who helped me put this case together. Also want to shout out Dr. Vijay Balaji, who actually introduced me to CP solvers. And yeah, I'm very grateful to be here and happy to present a case today.
That's so great, Ram. And what are you up to this week, Ram?
Nothing fancy. I work as a research assistant at the Philadelphia VA, so just churning out some manuscripts as usual, crunching some
That's
data.
good.
But
Which
yeah,
field, which specialty?
gastroenterology. So
Okay.
IBD specifically. So it's sort of fun. But yeah, no more football, so obviously it's going to be a little quiet. But looking forward to March Madness. So
Yeah, yeah.
yeah.
Awesome, Ram. Whenever you're ready, we can go ahead and get started.
All right. So we have five aliquots, and the fifth aliquot will reveal the diagnosis. I will stop briefly after I share some imaging, maybe to get your thoughts, and then proceed with maybe giving you additional labs if required. So, for the chief complaint, we have a 60-year-old female with 6 months of shortness of breath and chest pain.
Awesome. Mengyu, do you want to take the first one?
I'm happy to since you did the intro. Yeah, that's a very interesting chief complaint because although shortness of breath and chest pain are very common, 6 months is quite unique. But maybe I'll just start with the shortness of breath and chest pain. Uh, I think we learned from Ravi actually. Shortness of breath, although it's very the differential is pretty broad, and you can use the dyspnea pyramid to kind of guide you, lead through the different system, all the way from the metabolic, the acid-base problem to to blood problem like anemia, bad blood, no blood, or and mostly chest and in the chest like heart problems and lung problems. The differential is really broad, but the chest pain actually help you localize it to somewhere between uh, the mediastinum and the chest wall. So what I mean by that is that you can, so where does it hurt in the chest? It's usually where uh, the pleura. So for example, the pleura of the chest wall, like pleuritis in the setting of pleuritis or pleural disease, or if it's the pleura between the heart, so like around the heart, pericarditis, pericardial inflammation, and the myocardium itself. Usually, when it's inflamed, you can have chest pain. Uh, and when the vessel is involved. Of course, you can think about pathologies like uh, vascular diseases like PE, although 6 months kind of make it a little unusual. PE can present subacutely, but 6 months seems too long for it. Um, so, um, yeah, so maybe Youssef, you can share your thoughts about if the time course changes your differentials in a way. And also, yeah, I haven't talked about the age, which is also the age and gender is also maybe have could provide some hint.
Yeah, I agree with you, Mengyu. I think shortness of breath, we think lung, heart, and blood vessels in between. When you add pain, you want to think pleura or heart. And lungs don't hurt. And that's as Mengyu was saying, like the lungs are not innervated, so usually they do not hurt. So you want to look at another etiology. In real life, if this patient comes to you in clinic, I think you're gonna very quickly do a chest X-ray at least and a stress test. the most common cause of death, like worldwide, is coronary artery disease. And in real life, the biggest known misdiagnosis is going to be CAD. And if this was real life and we were not chasing zebras, then and this case was presented to me, I would want to rule out angina as a primary etiology. So I would start thinking about cardiovascular risk factors and should we consider stress testing. So that's where I'm at. Ram, can't wait to hear more.
Yeah, great discussion and great initial thoughts. Just to kind of look at the history a little deeper. So the shortness of breath was described as dyspnea and exertion, and she's been having this for the last 6 months. It's been present with basic activities of daily living, like getting groceries or walking from one room to another. It improves with rest after 5 minutes. And she also notes that she wakes up in the middle of the night gasping sometimes, but she is able to lie flat when she's sleeping. For the chest pain, it's sharp and stabbing, intermittent, lasts for about an hour, and it's aggravated with deep inspiration. It's non-radiating and non-exertional. She also reports chronic cough, which is not non-productive, but worse with deep inspiration. And she notes an occasional aspiration sensation when she coughs frequently. Um, in daily functioning, she can walk about 3 to 4 minutes on flat ground until she's already short of breath. Just a review of systems. She also reports diffuse body pain over the same time course. She also noted an oral ulcer on her top right gums, which is reduced with daily mouth rinses. No fever, no swelling in her legs, no chills, nausea, vomiting, diarrhea, abdominal pain, syncope, or weakness. And she also denies any recent illnesses or sick contacts. And that closes out the Selako.
Yeah, awesome, Ram. And I think as we're thinking through this case, we're gonna keep playing the tension of is this like lung, pleura, heart, or is this something in between, like mediastinum or the blood vessels? Whenever I hear of dyspnea on exertion, I primarily consider mediastinum or cardiac etiologies. And one thing to consider while you're taking history is to start to risk stratifying this patient in cardiac buckets. So how high risk are they for angina or coronary artery disease? And what are the things that have a high pretest probability? So the things that have a high pretest probability for coronary artery disease include chest pain that radiates to both arms or radiates to the jaw. So that has a high likelihood ratio for coronary artery disease. Otherwise, even the ratio for those is not very, very high. It's like predictive, so you still want to consider like testing. Other things I'm considering here is we hear about cough, and when we hear about cough, it could be from the lungs, but the heart can cause it too. Especially we hear that there is pain when or shortness of breath when lying flat. Is this like orthopnea? Is there a component of orthopnea there? However, the one thing that is counter to that is pain with deep inspiration. And that makes me consider pleuritic pain. And pleuritic pain has a very narrow differential, and you always want to consider things like the lung pleura or the pericardium as the major etiologies in the chest. Not a lot. I'm not taking this case significantly forward in this aliquot, but I think where my brain is that I want to consider early imaging to rule out structural etiologies. And if this were real life and the imaging was negative, then I would consider stress testing. Mengyu, what are you thinking?
Yeah, I totally agree with you. I was also my attention was caught by the pleuritic chest pain as well as the cough, in addition to the chief complaint that we had, the exertional pain. I think a lot of the cardiopulmonary components can cause exertional symptoms. But as you mentioned, the pleuritic chest pain, I think really makes me think again about the sandwich we talked about earlier, which a lot of them involves the causing the pleuritic chest pain, including mediastinal pathology and pleural, either around the heart or around the pleura. Although we don't hear like a positional type of symptom, so that like the patient can lie flat, which perhaps makes me think less about a pericardial inflammation. Um, but yeah, and the cough, what the cough helped me was that I think it really suggests something affecting the airway, either intrinsic airway problem, maybe involves the airway, but then extends to the pleura, as in a primary lung pathology, or it's causing some external airway problem, like something in the mediastinum or touching the diaphragm. Um, so I think those are still possible. Yeah, I agree. Some imaging will make a lot of progress. And but also curious to hear the past medical history and all that.
Yeah, and I don't know if we're gonna hear exam next, but one thing that you don't want to do is actually try to palpate the chest and see if there is tenderness. Like in the past, you would say like, "Oh, just palpate the chest," and then if it's tender, you consider this to be like costochondritis. But this has a very low likelihood predictive value for coronary artery disease. So it might actually distract you. Like they might hurt, but then they still have coronary artery disease, so you want to try to avoid that. So Ram, can't wait to hear more.
Yeah, great. Absolutely great discussion. And yeah, I think I can give you the past medical history as well as maybe add the exam as well, and then maybe go to the labs for the next aliquot. So past medical history is significant for the patient being diagnosed with SLE in her 30s. She did receive some medication for a short duration. However, she cannot recall the name of this medication, and she's not currently on any medication for SLE. Um, she also has fibromyalgia, hypothyroidism, anxiety, dry eyes, and periodontitis, for which she's getting levothyroxine, duloxetine, lorazepam, and cyclosporin eye drops. Her past surgical history is significant for an appendectomy, a cholecystectomy, or lower segment cesarean section, as well as a hysterectomy. Her family history is positive for her sister and niece having SLE. Her mother has hypertension as well as a history of type 2 diabetes and myocardial infarction. And her father also has history of hypertension. Um, in terms of social history and health-related behaviors, she lives with her disabled son and is a caregiver for both her child and elderly parents. And there's no history of tobacco use, alcohol, or any illicit drug use. And in terms of health-related behaviors, no history of TB and no recent significant travel to note. No allergies reported. And we maybe jump into the exam. Temperature is normal, BP 132/59. Respiratory rate was 17. She was sitting at 98% on room air. BMI was 28. Um, General exam, she was not in any acute distress, so she was a little anxious, but she didn't appear short of breath during exam. In terms of the head and neck, ENT exam, the right buccal mucosa did reveal that ulcer that she was talking about with significant inflammation. The respiratory exam had diffuse and inspiratory crackles bilaterally. Cardiovascular exam was normal. There were no murmurs, and you could hear both heart sounds. Musculoskeletal exam had no obvious telangiectasia or sclerodactyly, clubbing, and the skin was unremarkable. And that kind of closes, and of course, no organomegaly on the abdomen, and the neuro exam was normal. So that kind of closes out this aliquot.
Yeah, Ram, you're such an expert presenter. I really could uh, tell the patients like vividly just based on your description. So thank you for sharing. And maybe I'll tackle the past medical history through for the rest, and then Youssef, you can talk about the physical exam and add anything that I missed. Um, so yes, I think the past medical history is very interesting in that the patient has lupus, and it sounds pretty telling just based on like there's no reason for me to doubt the diagnosis. So, of course, then you think about when you layer on that, think about the chest pain and shortness of breath in a patient with lupus. Uh, your first consideration is that so whether it's related or not, uh, if it's if it's not related, of course, we have all the other differentials that we'll still keep in mind. But if we just layer on that and think what specifically in lupus patient, I think one thing that kind of raised higher on the differential is the things that came up higher is one is the pericarditis, which we already was interrogating and looking for features of that. Don't find those so far other than the pleuritic chest pain. I want to ask more about the pleuritic, the positional nature and the EKGs to look for those clues, and maybe like a physical exam to looking for rubs and an echo. And then the other is coronary artery disease. So either through thrombosis or embolism, which the patient has some exertional nature, although that doesn't explain the pleuritic nature of the pain, unless there's like a combination of etiologies. And pulmonary embolism also is there's increased risk. Again, the time course seems a little atypical, but I think just having to keep that in mind, especially although the patient's oxygen saturation is and heart rate is all normal, so that kind of lowers that possibility together with the timeline. And then would be curious about the medications. When I know certain medications can cause chest pain in lupus patients, like tacrolimus can cause like hypertrophic infiltrative cardiomyopathy, although we don't have that history. Although I don't know if cyclosporin, maybe not specifically. And it's just, yeah. And hydroxychloroquine, something lupus patients are commonly on and then can cause myocarditis. Yeah, and I will look for clues for like any lupus flare as well. The diffuse body pain is a little suspicious. I will ask if there's some change recently, and the oral ulcers. I think there's like a certain features that suggest more active lupus. Of course, you'll check inflammatory markers, and you would look for any joint inflammation, especially if that was part of the presentation of the lupus and presence of cytopenias. All the lupus features. There's like a scoring to test for lupus activity. Yeah, I'm going to stop rambling and see what Youssef has to add.
No rambling. I agree with you. To diagnose pericarditis, we would need pleuritic chest pain with either hearing a pericardial rub on exam or finding something on EKG or finding a pericardial effusion on the echo or POCUS. So you need two of those criteria to make the diagnosis, and then you can just treat for it accordingly. 1 in 4 patients with lupus have pericardial disease, so it's really common. The next question is, we hear these crackles, and is this a symptom of heart failure, or is this like some form of heart disease? And how do you know if there's heart failure on exam? So you can look for signs of right heart failure. This include things like lower extremity edema. That's one way to do it. The other things that have a high predictive value for heart failure is you can listen for an S3 or an S4. And then one thing that I learned recently is that a displaced point of maximal impulse has a very high likelihood ratio to predict a low EF. So you can put your arm, put it flat under like the nipple line and see where the point of maximal impulse is. If it's moved to the lateral portion of the chest, you can predict that the patient has a low EF on physical exam quickly. And nothing more to add. So crackles could be from the lungs. Rarely it could be from ILD, and folks can mistake crackles for other things, something else that they're listening to. But one thing that I would do early on is to get like a BNP level and get an EKG, and then take it from there accordingly. And other than that, we do hear the history of hypothyroidism and lupus, so this has significant autoimmune disease. So curious to hear what happened next, Ram.
Great discussion. Just the way both of you kind of broke down everything is incredible. Let me make your job a little easier now. So just the initial labs: WBC 6.8, hemoglobin 13.5, hematocrit was 276, MCV 93. Chemistry, sodium 138, potassium 4.1. Urine analysis was normal, no cells or protein. We had a normal ESR and CRP was 0.72, which was normal. Liver panel was also within normal limits. And the BUN and creatinine were also within normal limits. I think someone asked about BNP. BNP was also normal. And I'll probably give you a little bit of imaging first, and then I'll give you some more labs in the next aliquot. So we got an EKG, which was relatively normal, no arrhythmia or conduction abnormalities, no changes noted of significance. We also got a transthoracic echo showing ejection fraction of 64%, but the left ventricle wall was mildly thickened. The remainder of the heart was normal. The patient also did get a stress test, which showed no sign of ischemia. And maybe here I will share a picture of the chest X-ray to get your thoughts, and then we can go to the next aliquot. One second. Can you guys see my screen?
It's loading. Oh, yes.
Mengyu, I'm gonna rely on you.
Oh gosh. Let's see. Let's look at the PA lateral first. The PA first. On my first glance, it looked okay. Like I don't
Looks
see.
okay to me too, the PA one.
Yeah. On the lateral, you can try to see if there's any hidden like retrocardiac opacity or yeah, like the anterior anterolateral. I guess I'm not sure, but it looks the retrocardiac is a little bit fuller than I had wanted, than I had expected. Mm. And even above the cardiac looks a little more opacity than.
That's what I'm looking at as well, like right anterior to the trachea, maybe like some.
That makes me wonder whether there's a lung process, like a focal lung process hidden retrocardiacally or like something in the mediastinum, like in the but I really I'm not confident at all. And I think I might rely on a CT scan, like a CTA chest as the next step to help us make progress.
Yeah, I agree. It's a better character, like maybe something there, and then we'd get a better imaging to look at it better. And if you were to order like a CT chest, usually it depends on what you're looking at. So if you're looking at the parenchyma, you don't need contrast because the air inside the lung acts as a way to help you see abnormalities. While if you're looking at the mediastinum, you do need contrast to look at the structures. So that's why in this case you would need like a CT chest with contrast to see both the parenchyma and the mediastinum.
Would you get a CTA chest to kind of rule out PE or like a vascular process, or just like a regular CT chest with contrast, which one that will not time it for the pulmonary vasculature?
Yeah. I think PE is like lower on my differential at this point, just with like it is pleuritic, but it's been 6 months, so that's why I'm thinking that's likely, but I'm not sure. What would you do?
Me, yeah.
And we do see something at notifications. I'm thinking that's what's causing the etiology.
Yeah, that's true. Okay, we'll follow your guide, Youssef. Rams, you're welcome to
Yeah.
there you go. Yeah, keep sharing what happens next. Yeah, we're so curious.
Absolutely. So we did get just to give you some additional labs. And maybe I'll give you the chest X-ray read also, which was patchy bibasilar opacities and ground glass opacities. I think more so from the haziness that was noted kind of at the base, and as well as what both of you had described. And given the respiratory exam of having diffuse inspiratory crackles, the history of SLE, as well as the chest X-ray kind of being unrevealing. There was a certain tension of wanting to look at the autoimmune serologies. And so those were the initial ones were ordered, which I will give you. But before that, CK was normal. TSH, since the patient had hypothyroidism, was also normal. So the autoimmune serologies, ANA was negative. Double-stranded DNA was also negative. Rheumatoid factor was highly positive. CCP was negative. And SSA and SSB were not detected. Let me also give you the HRCT. I show you a video of the HRCT, and then maybe I can give you the confirmatory labs in the last aliquot, which would reveal the diagnosis.
And Ram, don't reveal the diagnosis just yet. Okay, give us everything but the reveal. Is that okay?
Okay, sure. Can you hold on? Can you see my screen?
It's loading now. Yeah, we can see it.
I'm just gonna reduce the speed.
I thought I saw some bronchiectasis changes, some GGOs in the left lower lobe. See them here at the bottom on the left, close to the pleura.
Did you want me to pause it and leave it here, or?
Yeah, and you can tell us the read, and then we can take it from there.
Sure. Okay. So the official read was the mild bronchiectatic changes in the lower lobes with peribronchial ground glass opacities. Multiple semi-solid nodules in both lungs. Largest one in the right lower lobe was 7 millimeters. No septal thickening or honeycombing is present, and no air trapping or collapse was noted.
Awesome. And the next aliquot will reveal diagnosis. Is that right?
Yes, but maybe I can present it in a way that will not reveal it if you'd like me to.
Okay.
But
Yeah. If
yeah,
you cannot reveal it, that would be good because we would like to have like one more discussion.
absolutely.
Yeah, we do have a lot of time and love to fully digest all the information. I realized we didn't fully discuss the labs earlier, so we can also reflect on that. Would you like to start first, Youssef, or
Yeah, I was gonna do like a breakout room for like 2 minutes now, so I'm gonna pause it.
That sounds perfect.
Welcome back, everyone. Hope you enjoyed the discussion. Would love to hear from you in the chat if you made any discussions or anything progress you made. Please put in the chat what thoughts you had. So to summarize, this is a 60-year-old patient with a history of lupus presenting for 6 months of dyspnea, so chronic dyspnea. Found to have bilateral crackles and on CT ground glass opacities with bronchiectatic changes. So Mengyu, did you want to just talk about the diagnosis of lupus first, and then I can talk about the CT findings, and then we can go back and forth?
Sure, yeah. We were wondering about the validity of the prior labeling of lupus, whether it's true or not, because I know earlier I said I didn't doubt it, but now I'm kind of wondering with the negative ANA and no other ENA so far. I think the only information we were given was the Sjogren syndrome, because initially I thought maybe he has the patient had a secondary Sjogren, but those were negative. So like when you see negative ENA, also a lot of negative ENAs kind of that made me doubt the diagnosis of lupus. Even when whether it's active lupus or not active, I think the negative NA also still makes me wonder. So I would be curious to dig more into how it was diagnosed in the first place. What were the symptoms, and was there positive ANA or other antibodies? And the RF being positive then makes me wonder, could this actually be a rheumatoid, but arthritis? But again, there's actually a very non-specific marker can be positive in a lot of conditions, including non-rheumatic causes, like in a lot of infections, for example, can have positive RF. Like it's even part of the criteria for endocarditis. Although I'm not thinking this patient has, given the lack of fever and the time course, but just know that how non-specific it is, especially with a negative CCP, makes me also not certain about the diagnosis of rheumatoid arthritis. But could this be some other inflammatory, either rheumatic or non-rheumatic diseases? Yeah, I think it really needs to investigate more into what symptoms she has in terms of doing all the rheumatologic review of system, joint pain, Raynaud's, like ulcers we know she has, but if joint pain, like what are the distributions? And we don't see kidney or cytopenia involvement, which then kind of make it not like at least not like the most classic lupus we see. Could it be a mixed connective tissue disease? But for that, you would expect to see positive. You would see ANA and anti-RNP positivity. Yeah, so those are my thoughts for just that.
Yeah. Thank you, Mengyu. And I used to find ILD really hard, so I'm gonna explain it in like two ways to make it a little bit easier how I understand it now. So you can stratify ILD by etiology. So you can consider is it connective tissue disease related? Is it sarcoid related? Is it hypersensitivity pneumonitis, or is it idiopathic? And these are the four big buckets you want to think of in general. And that's one way to stratify it. The other way to stratify it is actually look at the imaging findings, and depending on the imaging findings, try to guess which etiology it is. And these are purely radiologic patterns that you can consider. Look at the image and say, oh, this looks like this specific pattern, and because it's this pattern, the etiology is likely X. So before I start saying acronyms, so non-specific interstitial pneumonia is NSIP, and that's a specific pattern of imaging. And then when you see NSIP on an image, a radiologist will suggest that, then you want to consider, is this connective tissue disease related? Whenever you see things like UIP, which is usual interstitial pneumonia, which is a radiological pattern, you want to consider, is this idiopathic pulmonary fibrosis, which is different than connective tissue disease related. And different autoimmune diseases can present with different imaging findings. For example, rheumatoid arthritis classically presents with UIP pattern, although it can cause an NSIP. Lupus does not typically cause ILDs, at least not commonly, but it can be associated with other autoimmune disease. So we hear here that the patient has a history of dry eyes, and Mengyu brought up that could they have Sjogren's, and Sjogren's disease is associated with lymphocytic interstitial pneumonitis, although we do hear that the SSA and the FSB are not detected. And somebody mentioned this in the chat. If whenever you see bronchiectasis, you want to consider immunoglobulins just to see has the patient has been having recurrent infections. But you can also see bronchiectasis as like traction bronchiectasis. So the patient has some fibrosis, and then that pulls on the airways, and that causes bronchiectasis. So what do you do now? We have this ground gas opacity, some bronchiectasis, and where do we take it from here? So I think one thing you can look up is a ILD questionnaire. It's really cool, but that's what pulmonologists do. So they pull up a questionnaire that has all the etiologies of ILD, and they go through it with the patient. So they're like, do you have birds at home? Do you have pet parrots? Do you have a pillow with feathers? Do you have a jacket that has feathers, etc.? And it's like very detailed, but you go through every single like exposure that can cause ILD. Another thing is to do a rheumatologic review of systems to see which bucket would this patient fall under. So are they gonna fall under? We hear that the RF is positive, so we would do a review system to see if they have any symptoms of rheumatoid arthritis or this like a mixed connective tissue disease picture. And then what about the treatment? So usually the treatment depends on the etiology. If it's connective tissue disease related, the treatment is immunosuppression primarily. If it's idiopathic pulmonary fibrosis, the treatment is antifibrotic therapy and pulmonary rehab. So the treatment is based on what you decide the etiology is. So here I think we're suspicious for something autoimmune related. So I worry that we would want to do a screening the patient for all review systems for autoimmune disease and see, and then asking about exposures, and then maybe considering empiric therapy, and talking to pulmonology, maybe doing a bronchoalveolar lavage. Mengyu also mentioned other etiologies, like should we consider infections and malignancy? Mengyu, do you want to talk about those as well?
Sure. Yeah, when I hear about the GGO, like semi-solid kind of translate into GGOs, and we know like there's this we like to talk about how we can feel the alveoli, like partial filling. GGO means partial filling of alveoli. So could it be water, pus, uh, uh, inflammations. Actually, that's a separate. So water, pus, blood, protein, cancer cells, or like other inflammatory cells, which actually has like a broader differentials. So I think we kind of ruled out water and blood is something we consider, but 6 months is a little too acute for like a DAH. Also, that's something that SLE can classically cause, like a DAH. And the protein, I think, is something could there be like PAP? But PAP could be secondary to a lot of things. And then cancer we talk about, but we like, of course, could ask about weight loss or symptoms like that. It's a little not really thinking about that right now. And the inflammation what kind of inflammation could be. And so kind of going back to the ILDs. So actually one thing I wanted to kind of also add, which was also commented in the chat, like lupus can be associated with, we don't talk about lupus in lung a lot, but I do know that it can cause a lot of different types of ILDs, like NSIP and OP are the most common. And in the acute setting could be LIP, like lymphocytic interstitial pneumonitis. And then other things like could be something non-specific, like acute pneumonitis, DAH, like we talked about earlier. Otherwise, the things we are not considering are like shrinking lung syndrome, pulmonary hypertension, thromboembolism, pleuritis, which we don't see on imaging or get on history. So whether it could be just one of those non-specific pneumonitis or the NSIP. I think the GGO pattern makes you think about NSIP. OP might be more inflammatory features, like more if there's like more chronic component you think about, like NSIP on have some subacute component to it. I don't want to pretend I'm a pulmonologist because I'm not. And then the other question I was thinking was whether the bronchiectasis could be a clue to something, because I don't associate lupus with bronchiectasis, although I assume if there's something chronic, like a chronic infection, whatever going on, could cause like these chronic changes. But when I look for bronchiectasis overlap with autoimmune, like rheumatoid fact, rheumatoid arthritis is something that would come up. Other things are like MPA or Crohn or IBD. Yeah, that's like I wonder if I should take the feature of bronchiectasis into the consideration. And then finally, one thing I was thinking about, like I just noticed the imaging when we were interpreting the imaging earlier. I noticed there's like a lower zone predominance, which I used to look into like what kind of GGOs tends to involve the lower zone because that helps with differential. And the feature, the difference between upper zone and lower zone is that lower zone is more blood flow, so it's more gravity dependent. There's like more stretch and shear stress when you like breathe in and out. So it would be associated with diseases that are exposed more exposure to like soluble or hematogenous agents, versus the upper lung zone is more ventilated. So like more like granulomatous diseases where like there's stuff, foreign body going to the airway. So for lower zones, you would be seeing in fibrosing lung diseases, which includes like IPF, NSIP, or CTD, because they have immune complexes like depositing in these blood-rich areas. Otherwise, there's like asbestosis, because those are heavier foreign bodies, and then fibrosing drug reactions. So I like look into the medication. I don't see clearly like fibrosing agents. Otherwise, could be just benign age-related, smoking-related conditions like aspiration, and pulmonary edema as well. But we don't get that history. So again, I think going back to whether this is a NSIP, perhaps related to some CTD. Yeah, I'll stop rambling here.
Yeah, and I think for next steps, Mingyu, I'd love to hear what you would do next. But I think everyone with ILD should get like the questionnaire, like we said. You would get like the immunoglobulin panel. The infections that can cause this, Aspergillus, we could potentially cause this, although we don't hear about immunosuppression. Non-tuberculous mycobacteria, like love to live inside these like bronchiectatic changes and can cause them as well. So that's like another etiology. Malignancy, possible, but less likely. So I think I would be talking to pulmonology, seeing if we would need to do like a bronchoalveolar lavage, send for cultures, and then if everything is negative, potentially starting an immunosuppressant. What would you do, Mengyu?
Yeah, I think, yeah, I guess BAL would make sense. Another condition that came to mind is like a MAC can cause Lady Windermere disease in someone who's previously, but I guess those are like in patients without previous like those lung disease, but can have like a bronchiectasis on chest imaging, usually in the right middle lobe, and they can have like these nod. Those just came to mind, but I just don't see any systemic features to suggest that. So, but I'm curious. I would consult pulmonology for sure. I guess I would agree with. Yeah, I wonder if there's any way we can make progress without a BL, but since the patient's oxygenation is fine, I think that's a reasonable next step. Yeah, I'm curious
Yeah,
to
or
look.
empiric therapy, and then seeing what happens. I'm curious to see what happened in their real life from.
Sorry, was that my cue? Sorry, my bad. All right. So maybe I can give you some more information if we have time, or if you'd like me to
Yeah,
go
I
through.
think just go through the entire thing.
Oh, okay, perfect. Okay, so all the discussion was incredible. I think you hit all the right points, and maybe just to give you some additional information, as because this is how it came in as well. Um, with regard to her SLE history, so the patient at the time of presenting, she did have joint swelling along with the facial rash and bone pain, and she did receive medication for this for a short period of time. She did follow up with a private rheumatologist, but this was almost over 30 years ago, and she was lost to follow up. So she essentially did not have any treatment for the SLE after that. Um, we did the goal obviously in the future was to repeat the ANA, because I mean sometimes you can you might get a negative, but it was worth considering getting another one given the history. But I guess for this case we didn't have that information on file. But just to kind of close this out, we did get pulmonary function tests given the increased suspicion for ILD, and so the total lung capacity was 4.9 liters, 65% predicted. Residual volume was 2.02 liters, 69% predicted. The spirometry revealed a functional vital capacity of 2.93 liters, which is also 62%. FEV1 was 69%, and FEV1 by FVC, the ratio was 79%. The DLCO was 48% predicted. And the interpretation of this was that this was likely a restrictive pattern of lung disease. We got the additional autoimmune labs where RNP antibodies was highly positive. Smith antibodies were also highly positive. Anti-U2 RNP as well as anti-U1 RNP antibodies were positive. We also saw anti-SSA elevated, even though SSA and SSB were not detected. Anti-scleroderma, Jo1, aldolase, NXP2, T1F1, anti-MDA5, all of the others were negative. Given the positive RNP, the U2 RNP, and the SSA, the working diagnosis was mixed connective tissue disease overlap with interstitial lung disease. The patient did get a dose of prednisone because we were waiting for the patient to go get a rheumatology to get completely evaluated before they were being put on, say, some immunosuppressive therapy. So the patient did receive prednisone and actually had some improvement in symptoms. And that kind of closes out this diagnosis.
Oh, wow. A lot of applause. Such a cool case, Mohammed. Thank you for presenting in such a breathtaking way. Yeah, I think really it sounds like the ENA panel actually showed us the kind of suggestive or definitive clues towards the final diagnosis. Uh, yeah, I feel like I have a lot to reflect, but really a great learning journey, and learn a lot from you as well, Youssef. I love your evidence-based approach to the common medical problems.
Thank you, Mengyu. Mohammed, can't wait to learn from you.
That's a very rich case. Thank you, everyone, for discussion and presenting. So let's get started with the chief. So this patient presented with a long history. Let's say it's chronic history of shortness of breath and thoracic symptoms. So the thoracic symptoms, we start talking about how broad shortness of breath it is and how chest pain narrows down the differential between the mediastinum and chest wall, and to include inflammation causes and vascular causes. For example, pericarditis and um, pleuritis, and also coronary artery disease. The patient also mentioned pleuritic chest pain, which really narrows to the pleural and pericardial spaces. The cough the patient has make us think either of cardiac or pulmonary causes. Pulmonary pathology infiltrating the pleura is a possible cause for the patient chest pain. Or a cardiac, since the patient have orthopnea, so the patient could have a cough. As we move to the patient past medical history, we found that the patient has lupus history. So lupus, now in the foreground, we have thoracic symptoms, make us really localize into coronary artery disease or pericardial causes. So here we need EKG and echo to see what are the causes. Moving to the examination, further information revealed inspiratory crackles. So this moves us to the interstitial lung disease realm. Also, we consider pulmonary edema. To exclude cardiac causes, or not exclude, to really include cardiac into our differential. In the examination, patient have left-sided heart failure. We considered examining the heart sound, S3 and S4, as well as deviated point of maximum impulse. So getting this information, the patient history, examination, and lupus history, we needed HRCT to define the problem. HRCT, if we are looking at the parenchyma, we need it without contrast. If we are looking at the soft tissue or mediastinum, we need it with contrast. So the getting the GGOs and the findings, then we have to divide the findings to include um, further etiologies of the patient in interstitial lung disease. So interstitial lung disease is either classified based on the etiology or the radiologic findings. For example, hypersensitive pneumonitis, connective tissue disease, or idiopathic pulmonary fibrosis, or by the radiologic appearance, for example, usual interstitial pneumonia or non-specific interstitial pneumonitis. In patients with SLE, non-specific interstitial pneumonitis is most common, as in patients with rheumatoid arthritis, which also can have usual interstitial pneumonia. So for the treatment of these conditions, treatment is dependent on the etiology. If it is something autoimmune, we need to consider immunosuppressant. If it is something idiopathic, we need to consider antifibrotic medications. Also, the site of fibrosis or these findings in the lower zone really make us think about soluble or hematogenous agents causing fibrosis. And next step in our management was either infection screen, immunology consult, and also questionnaire to include what are the causes or the etiologies or the exposures the patient have. And thank you very much.
Yeah, thank you so much, Mohammed. Excellent teaching points. Thank you. Such a pleasure to discuss with you as always. Thank you, Ram, for the excellent case. I'll see you all soon. Have a wonderful day.
Thank you, Rams. Thank you, everyone. See me, Muhammad.